to see you all on a Monday afternoon for us, but certainly people from around the world that are joining. So excited to have you here for our next ACVNU Journal Club. Today, Dr. Autumn Harris from University of Florida will be presenting this article, The Effect of Amlodipine on Circulating RAS System in Healthy Cats. This is, I think, obviously a very important topic to us, and I think as nephrologists, urologists, we are and should be the absolute experts in hypertension. Cardiology tries to steal it from us, and I don't really understand why, because it is not a primary cardiac disease in our patients. So this is exciting. I'm really pumped to go over this article and have some discussion pick up. And like always, let's try to make this more of an interactive discussion rather than just a lecture. It's great that Autumn is going to be leading this and sharing some information with us, but please go ahead and unmute your microphone when you'd like to ask a question or have some comments. You can also throw things in the chat, and I will try to be monitoring the chat as well too, but let's definitely try to make this interactive because that is just a whole lot more fun. So again, thanks everyone for coming, and without any further delay, welcome Dr. Harris. You can go ahead and get things started for us.
Yeah, thank you, JD. So like JD said, I was going to present this paper that recently came out of the effect of amlodipine on circulating RAS in healthy cats. Okay, there you go. So just to kind of start off with a little bit of background information, there's the ACVM consensus statement, which hopefully everyone is aware of, on the guidelines for identification, evaluation, and management of systemic hypertension in dogs and cats. And hopefully everyone, just a little background, but systemic hypertension is very common, particularly in older cats. It occurs commonly secondary to CKD or hyperthyroidism as the most common causes. If left untreated, it leads to target organ damage, including ophthalmic abnormalities, as well as potentially renal and brain abnormalities that can happen. And with the consensus guidelines, the first-line medical treatment for cats is typically then amlodipine as the recommendation, which is a little bit different than the recommendation in dogs, but I'm mostly going to focus on cats today. There is a large volume of literature that exists that indicates that amlodipine decreases the systolic blood pressure by about 30 to 70 millimeters of mercury in the vast majority of hypertensive cats, and that systemic hypertension is well documented as a risk factor for development of proteinuria in cats. And in turn, proteinuria is associated with increased likelihood for disease progression and shorter survival time in cats with CKD. And studies have documented a significant reduction in proteinuria with control of hypertension while administering amlodipine. These are just two of the main papers in the past literature, but there are a lot of them. And then ACE inhibitors is also been looked at as monotherapy, which is not recommended for the treatment of feline hypertension. And this was based off some studies in cats with experimentally induced CKD that had mild hypertension. And benazepril was only shown to decrease their blood pressure by about 10 to 15 millimeters of mercury. There has been some evidence with an ACVM abstract to suggest that the addition of benazepril as an adjunct to amlodipine could improve blood pressure control in cases where amlodipine monotherapy failed to control the systolic blood pressure by its own. And where questions have come with this is that can there be chronic RAS activation can potentially have maladaptive or a lot of negative effects on our patients, particularly those with kidney disease. And so there's been a lot of questions with what happens after amlodipine treatment, and could there still be chronic RAS activation that's not being targeted when we just use amlodipine, and what impact could that have on our patients? So there are a lot of questions regarding the potential effects of amlodipine on the activation of RAS in cats particular, which is where there may be some knowledge gaps and where this study was trying to help answer some of those questions. And we now have access to comprehensive RAS fingerprinting, which used to be available out of this country, but now is available at the University of Kentucky. And so this is kind of what these fingerprinting arrays will look like. The blue dots are thought to be inert, the green dots are thought to be beneficial, red dots are thought to be detrimental. This is kind of all of the molecules that you'll see with the core RAS fingerprint. And then there are what's thought to be the classical RAS pathway and then the alternative RAS pathway, where the classical RAS pathway refers to the peptide cascade from angiotensinogen to Ang1 to Ang2 that's mediated by enzymes renin and ACE, which leads to increased adrenal production of aldosterone. The physiological consequences of activation of the classical RAS cascade can include vasoconstriction, sodium and water retention, and myocardial and vascular fibrosis. And these are considered maladaptive in the context of chronic RAS activation and are really the targets of a lot of our RAS mitigating treatments. But then there's also this alternative RAS pathway that's been characterized that involves the breakdown of Ang2 to Ang1,7 by the enzyme ACE2 that has downstream signaling through the MAS receptor that can lead to vasodilation and diuresis and natriuresis and mitigation of vascular inflammation. And so this alternative pathway provides an internal counter-regulatory mechanism that can partially mitigate the negative effects of Ang2 and aldosterone. So it has very important roles. So the objective of this study was that they wanted to evaluate the pharmacodynamic response to amlodipine administration compared to a placebo on a comprehensive array of circulating RAS components of both the classical and the alternative pathways. And they hypothesized that amlodipine would increase concentration of all RAS peptides compared to placebo. This study design for this study was a prospective double-blinded placebo-controlled crossover design study. Their study population was 20 cats. They had to be greater than 5 years of age, and they were owned by students and staff of Iowa State University. They divided the cats into two groups, so they had 10 cats in each group. Group A was an amlodipine-treated group, and Group B was a placebo-treated group. And then they had equal numbers of male-neutered and female spayed cats, and they had 50% of each sex in each group. Their inclusion criteria was that the cats had to be systemically healthy. That was determined by history, physical exam, CBC chem, T4, blood pressure, and an echo. They had to be on a stable, consistent diet to be in this study, and they could not be on any concurrent medications other than heartworm, flea, and tick preventatives. And the exclusion criteria was the presence of hypertension, systemic disease, or cardiac disease, or if the cat had a fractious behavior that was not conducive to lots of blood sampling. So this is kind of a figure from the paper that I thought did a really nice job of breaking down the study timeline for this. So at visit 1, they did baseline measurements, which included the CBC chem, T4 blood pressure echo, and the comprehensive RAS fingerprinting. They did this at 8 a.m. And then the cats were randomized by sex into Group A or Group B. And then they were treated with either amlodipine or placebo once a day for 14 days. And then they were brought in for visit 2, which went from day 14 to day 15 because it was an overnight monitoring visit. And the last dose of amlodipine was given that morning by the study staff before the study was started. And they collected blood at time point 0, 4, 8, 12, 18, and 24 hours. And at the 24-hour mark, they did a CBC chem, and then they did a blood pressure and an echo. Then they allowed for a 4-week washout period, and then the cats crossed over. So if they were in placebo, they then went to the amlodipine group, and if they were in amlodipine group, they went into placebo. They did another 14-day treatment period, and then they did the same thing at visit 3 that they did at visit 2, where the cats came in and had blood sampling at hours 0, 4, 8, 12, 18, and 24. And also had the CBC chem, blood pressure, and echo at the end of that. And then they measured plasma amlodipine and RAS biomarker quantification, which was performed by liquid chromatography mass spec at all of those time points. And so for their results, their study population, their median age was around 8, and it went from 5 to 14. None of the cats had known underlying systemic or cardiovascular disease that was found on any of the testing that they did. And they didn't find any clinically relevant abnormalities in the clinical pathologic or echocardiogram variables at any of the time points over the study, though they didn't really give you the data to look at. And then they did the pharmacokinetic time course of plasma amlodipine after the final dose of amlodipine administration. And so here they are showing the median area under the curve for amlodipine over the 24 hours. They didn't find it different between the groups of when you got amlodipine in the study time point. I found it really interesting how wide the variation was in amlodipine concentrations at the different time points. And I didn't know, I was unable to get a copy of some of the original studies where they did pharmacokinetics with amlodipine. So I didn't know if anyone like on the call knew if this variation has been shown in the past with amlodipine things. It just seemed very wide to me. I don't know if anyone else had any comments on that.
Well, the plasma amlodipine concentration here is just that. It's not normalized to body weight. So a cat that receives a higher dose could potentially have a higher plasma concentration of amlodipine, even though its volume of distribution might also be different too. So it'd be interesting to see if the plasma concentration, when normalized to body weight or extracellular fluid volume or some marker of the cat's size, might show maybe a less variability around there. That's one thing that's not accounted for just by looking at the raw plasma concentration of the amlodipine.
And then they did what they called comparisons of 24-hour time-weighted averages of the RAS biomarkers between the treatment groups. So the A is the amlodipine, A is the placebo-treated group, and B is the amlodipine-treated group. And what you can see by looking at the little balls, and they also have a table that give you the exact numbers, that the time-weighted averages of ANG1, ANG2, ANG1.7, and ANG4 were significantly higher in amlodipine-treated cats compared to the placebo. And then they also looked at overall correlations between amlodipine concentrations and these RAS biomarkers, and there was no statistically significant correlation between any of them. The other thing that they also looked at was they did look at the blood pressure between the treatment groups and then before and after treatment, and there was no change in blood pressure from baseline to after treatment in any of the cats. So what they concluded from this was that RAS biomarkers from both the classical and alternative pathways were high in amlodipine-treated cats compared to placebo and healthy cats. And so one of the questions I had, well, how does that compare to the literature? What I could find was that there's been 3 papers that have looked at RAS biomarkers in cats in the literature reporting like amlodipine as part of these. So the first one was in 2014 that examined plasma renin activity and aldosterone concentrations in normotensive and hypertensive cats. This was done by different methods than the comprehensive like RAS fingerprinting, and these cats had variable renal function, and then in response to antihypertensive therapy, they had 23 cats in that study that were hypertensive that were included in doing a comparison of renin and aldosterone pre and post amlodipine concentration, and 60% of those cats were azotemic. And what they found was that there was no change in aldosterone levels, which is also similar to what was found in this study, but there was a significant increase in renin post-treatment. And then the second study that came out looking at this was this GMT study that came out, I think last year, that utilized the comprehensive RAS fingerprinting similar to what was used in the current study. They had 34 healthy cats in this study, which are in group A. They had 15 cats with systemic hypertension. They had 8 that were not treated, which is the group B. And then they had 7 cats that were treated with amlodipine, which is in C. And so what they found was that there was no difference in the RAS biomarkers between the healthy cats and the untreated systemic hypertensive cats. But the hypertensive cats were treated with amlodipine, showed increases in multiple markers of both the classical and alternative RAS pathways, which included a lot of the ones found in this paper with Ang1, Ang2. They did see an increase in aldosterone in this study, Ang1-7, Ang3, and Ang4. And then the last paper came out at the end of last year that compared untreated normotensive cats, which were 9 cats in this group here. And then they had hypertensive cats with CKD after amlodipine treatment, and they only had 5 cats in that group. And then amlodipine treated cats with systemic hypertension had higher concentrations of a lot of the same angiotensin peptides from both the classical and alternative RAS pathways. But this study also found an increase in aldosterone, which was a little bit different than the first study and the current study. And so we know the vascular specific effects of calcium channel blockers like amlodipine will vasodilate those peripheral arterioles, including the glomerular afferent arteriole, which may then decrease the blood pressure sensed both centrally and locally in the kidney, leading to that juxtaglomerular release of renin, leading to increases in both the classical and alternative RAS pathways. But what I think we don't really know is it's complex, the effect that these drugs have on RAS, and that there is probably a balance between both the classical and alternative RAS activation. These pathways are counter-regulatory in their effects on fluid balance and vascular tone. And I think it's really challenging, or we don't really know what, the relative degree of classical versus alternative RAS activation is clinically relevant. So this study in healthy cats found a 56% increase in the classical side of this pathway and a 38% increase in the alternative side after amlodipine treatment. But I don't really know, is that keeping it in balance or not? Is that enough? I don't know if that's clinically important. And we still don't really know whether the RAS activation caused by amlodipine therapy is detrimental long-term. And we don't really know if adjunctive treatment with RAS mitigating drugs is warranted when we're treating our systemic hypertensive cats. And then some of the limitations to this study were, these were presumed healthy cats that would presume to have a normal baseline RAS activity. We don't know that for sure, but that they're presumed, which is different than cats with naturally occurring systemic hypertension or potentially experimentally induced RAS activation or cats with CKD. Amlodipine didn't really change the blood pressure in these cats at all from before or after treatment. They only measured circulating RAS metabolites in the blood and not at the local renal tissue concentrations, which might be different and more relevant in the pathophysiologic sense of systemic hypertension. And of course, this study only looked at amlodipine therapy, and so it didn't compare effects of amlodipine on RAS activity to the effects of patients that may have been on amlodipine or ACE inhibitors combined, or just ACE inhibitors. So those were some of the major things that I had with this. I didn't know if people had other thoughts or comments.
One of the things that I thought was interesting when you compared these results to some of those other studies, the Ward study from GVIM found that the cats who did have systemic hypertension did have a significantly different plasma renin activity than those that were healthy. And it's interesting that the current paper did not show any difference in renin activity. And, it kind of brings up like, well, how does the process get started? If renin is not any more active, then how is all the downstream effects occurring? Or is there a different pathway to its activity, or is it just regulated so closely that the concentrations stay fairly similar? But it was interesting not to see that, because you would imagine, okay, if the vasodilation was affecting the kidneys and the juxtaglomerular apparatus was responding appropriately, then it will increase the plasma renin concentration, and that should hopefully be picked up by the assay looking at renin activity. And it wasn't seen here. So
Hey JD,
Yeah.
can I offer? This is Bianca.
Yeah.
I'm pretty sure I just recently reviewed that wards study because of an ACVM lecture. I think that is true, but then I think they had about 15 hypertensive cats in the ward study, and about half were treated with amlodipine, half were untreated. And when they looked at the untreated subset, there was actually no activation of the RAS noted. So which is more in line with this.
Yeah, the B is the untreated cats, which they did not show a statistically significant difference between the untreated hypertensive cats versus the ones that were treated with amlodipine, which is the C.
Right, which is so interesting, right? That cats do this. It looks a little bit more like the data from the RVC with the low renin and then high aldosterone.
Mm-hmm.
Yeah, it's so interesting. Like, what's the trigger? What's the first domino to fall to knock over to get the process started?
Right, and I really don't understand. We this is not yet peer reviewed. We're still writing this manuscript, but we just finished a study looking at naturally occurring hypertension in cats. Most of them had CKD, and we did fingerprint before and after amlodipine as well. And the hypertensives before treatment tended to have low PRA. And this was the PRAS, the one that's calculated from the RAS fingerprint and not actually measured PRA, and then high aldosterone. And I just don't know. It seems like in these cats, the aldosterone release might be independent from renal release, like the RVC group had suggested in their publications.
Yeah, that's wild to me, and just suggests that there's some pathway that's there that we're waiting to stumble upon. So very cool.
And I think that Autumn's point about the intrarenal RAS is really important as well. In people, I mean, at least the folks that this is somewhat subject to debate, but the folks that study the intrarenal RAS think that it is so important in the pathophysiology of kidney diseases and hypertension, and it's probably so unknown to us because we rarely study it since it's much more invasive to look at.
And Bianca, how exactly do they quantify that? Is that done through tissue sampling and proteomics?
Yeah, it really depends on the study. One thing that some studies have looked at is urinary angiotensinogen, which is proposed by the groups that believe in it as a marker of intrarenal RAS activation because it correlates very well with angiotensin 2 immunostaining. And so they can use that for a few studies clinically, but in a lot of ways is, from rodent models and then from renal biopsy samples from people with CKD and looking at angiotensin 2 immunostaining and some other similar assays.
Yeah, that's really interesting. That's great. Other comments on this? Questions or comments on the paper in general? I think I saw that Jessica was on, and one of the other things that I noted too is that the baseline blood pressure they measured in these cats seemed to be at that initial time point, but then I think they say that for visits 2 and 3, the cats were given gabapentin prior to decrease the stress, and I thought that was just a little bit interesting to not have that on day 1. And Jessica did have some data that she presented at ACVM this past year on the effect of gabapentin in blood pressure. Do you have any comments or anything you'd like to share about that, Jessica?
Yeah, JD, can you hear me okay?
I can hear you fantastically.
Great. Yes, so actually that paper did just get accepted. It should be out pretty soon. But I saw that in the study design too and went, oh boy, well, that's definitely confounding. Now, it was a lower dose. It was 50 milligrams. So maybe at that decreased dose, we wouldn't expect to see as much of an effect. I mean, I appreciate the cats got the GABA considering the blood sampling protocol that they went through, but I agree it would have been a cleaner study design for them to have gotten that gabapentin at baseline as well, because that definitely does confound that a little bit. And then if there was, I mean, and we also don't know the effect of gabapentin on RAS. I mean, it is also a calcium channel blocker. So if you're saying that amlodipine, part of the reason why, it's its mechanism of action of amlodipine that this effect is occurring, we should be asking the same question of gabapentin potentially.
Absolutely. And they do mention that in their discussion later.
Yeah.
And Jessica, would you be kind enough just to, for anyone who hasn't heard your presentation, or just give us the kind of very brief findings of your paper that soon to be published?
Yeah, you bet. So we did a placebo-controlled crossover study looking at the 10 mg per kg dose of gabapentin in both normal cats and cats with chronic kidney disease. We had been seeing some concerning anecdotal effects, even at a relatively low dose, where we expected that there was truly a blood pressure lowering effect. And some cats actually had blood pressures below 100. And when they shouldn't, like previously they had perfectly normal, reasonable blood pressures. And then in those moments where they were quite sedate, they were actually somewhat hypotensive. And that was particularly occurring when we saw patients that probably were prescribed too high of doses for their azotemia due to the renal excretion. So we did this prospective study to try to figure out if we could actually document that happening, because there are several papers out there already that document with their study design that there isn't a blood pressuring the lowering effect. And some of them are smaller studies, some of them don't cross over. So it might be the timing of it as well. So there's a lot of variability in the study design of these previous studies that are out there. So we tried to get a decent number of cats in both the normal and the chronic kidney disease group. And I had actually hypothesized that the effect would be more profound in kidney disease. And actually the median change in blood pressure was actually quite similar between groups, interestingly. So even the normal cats, there were cats who definitely had a significant decrease at the gabapentin blood pressure visit in their blood pressure. And in each group, one of the normal cats and one of the chronic kidney disease cats had a blood pressure below 100 on the gabapentin when they had your typical reasonable range while not on the gabapentin. One of those cats, that was like I think 95 degree millimeter of mercury difference between the two visits. So, I mean, suffice it to say, I was convinced by the data that the effect is real, and it does kind of unfortunately complicate our measuring of blood pressure in these cats. And then Bianca also had the telemetry study, which I think also is a very interesting look at things, because I actually started to wonder whether this is a peripheral vasodilation effect, because in her study, they didn't see, she of course can speak to this better, but what I was intrigued by the data was they didn't necessarily see it with the telemetry, but there was more of a difference when they used Doppler. And I should say we were doing these blood pressures with Doppler, and sometimes we really struggle to get the blood pressure with Doppler when they've had gabapentin or had too much. And then also it's very common for the text to comment that when their gabapentin dose is too high, it's more difficult to draw blood and that the blood flow is quite sluggish. So to me, I actually wonder if it might actually be, maybe it's not their true, if you did it with telemetry blood pressure, but it's actually the fact that we're using Doppler to take the blood pressure. You might potentially be getting a weaker reading for that from that perspective. So that's kind of a theory that we threw out there as well.
That's great. That's super interesting. Thanks for that, Jessica. Bianca, do you have anything to follow up on that?
Yeah, no, Jessica summarized it perfectly. Our study was very small. We had 6 cats that were healthy, and we instrumented with blood pressure sensing telemetric implants. Unfortunately, of course, one of the implants failed, so we ended up with 5 cats. The variability of the responses was, and this was a placebo, it was double masked and placebo controlled. The variability of the data was huge, so it's always a bit challenging to prove any differences. There was an overall trend for blood pressure to be lower in the at-home environment for those cats when we measured for 4 hours after dosing. And then the really fun part, as Jessica mentioned, is that when we subjected these cats to simulated vet visits, so we put them in carriers and drove them around and brought them to the vet hospital and then measured Doppler blood pressures while also measuring telemetrically determined direct blood pressure. There was a trend, again, only 5 cats, but there was a trend for the Doppler to be even worse at estimating blood pressure than usual and underestimating blood pressure when you looked at the placebo versus the gabapentin visits. It was really fascinating, and we probably just need to do this study again in a large number of cats.
Wow, that is that is great information to have, but also very humbling in our ability to know what's happening with blood pressure in cats.
Completely. Yeah, and honestly, again, our study was very small. The one thing I would highlight from our study, which to me was the one point that we can certainly take from that, is that in every single visit, regardless of whether the cats received placebo or gabapentin, blood pressure measured directly in the hospital was higher than the at-home average every single time. So even cats on gabapentin experience situational hypertension, or at least situational increases in blood pressure, even if they didn't reach hypertensive status. So I thought that was really interesting.
Yeah, that really is. And that kind of goes to the whole white coat hypertension that we deal with so often. And this paper didn't find that amlodipine decreased blood pressure in these healthy cats. And, you know, I'm sure we give amlodipine to cats that at home are probably normotensive, you know, I think I'm just as guilty. I think we just can't control for the factors of stress in the individual cat. And I'm sure we've diagnosed, or we presume that there was systemic hypertension and we treat it when that's not the case. But I can't say I routinely see cats coming in acting and showing clinical signs of hypotension very often on amlodipine unless they have a reason to be volume depleted. If the cats are still eating and drinking fine, then they seem to be okay. But if the cats suddenly stop eating, they're having GI upset, that's when we tend to see them come in hypotensive, which maybe that was going to happen anyways because they have some reasons to have some volume deficits. But it's just so interesting that a normal cat can tolerate it without having any change in their blood pressure. And that's good if we accidentally administer it to a patient who doesn't have hypertension in their home environment. But you do wonder if that same thing is true for a patient with kidney disease, with other underlying problems where maybe their regulatory mechanisms are not absolutely normal, and maybe they will have hypotension at home when they're not exposed to the stress and the rectal thermometer and everything else that might come along with a visit. Anybody else have comments, suggestions, questions here?
I wanted. Go ahead, Jessica.
Yeah, sorry, Bianca. One other thing that I did think was interesting was one question that we got asked with our project was the combination of amlodipine and gabapentin and whether it would potentially be considered problematic. And we only had a couple of cats in our kidney disease group that actually were on amlodipine, and I purposely included them because we had never clinically appreciated that maybe there was a concern to give gabapentin to a cat on amlodipine. And I can't say that those cats had any exacerbated a response from getting the GABA, but that's another reason why this paper was interesting to me, because now you have a full set of patients that actually did get both together, and there doesn't necessarily look like there was a concern there.
Yeah, that kind of fits with my experience as well too. That's really interesting. Bianca, did you want to share something?
Yeah, I was going to make a comment on the ratio between the beneficial or alternative RAS and the classical RAS, because I think if we go back to that, it is such an interesting discussion, right? Up until this point, all we could say was that amlodipine activated the RAS based on changes in PRA, and now we have this way to look at these other markers. I think I don't think they reported, but some of the groups that have done RAS fingerprint have looked at something that they call the ALT-S, which is the alternative surrogate, which essentially is a calculation of the ratio between the beneficial peptides like 1,5 and 1,7 and the potentially negative peptides like angiotensin-2. And they didn't report it here, but I'd be curious to see what the ratio was and if that changes with treatment. And then I go back to thinking, well, but then what does that actually mean? Because my understanding is that, for example, the angiotensin-2 type 1 receptor is the predominantly expressed receptor. So even if the ratio in terms of the peptides is different in some way, I always think about, the availability of the receptors as well. So I guess my main comment is this is so complicated and my head often hurts trying to interpret all of these data.
I think that's probably a shared endpoint for most of us, myself certainly included. One of the things that I thought was interesting when we look at the alternative pathway, and I don't know, Autumn, if you could maybe bring up one of those figures in your slides. Perfect. So when we look at some of the enzymes that are involved in that alternative pathway, neprilysin is one of them. And there are neprilysin inhibitors. So sacubitril is a neprilysin inhibitor, and that's used in people. And in fact, there is a drug which is sacubitril with valsartan together, and that's the drug Entresto, which you potentially have seen commercials for, and that's used to treat heart disease in people, which is interesting because when you look at the effect, if we're saying, some of these alternative pathway substances are actually beneficial, that they could be natriuretic, they could cause some degree of vasodilation, they could help decrease blood pressure and sympathetic tone. That use of neprilysin inhibitor is going to help keep those active. So with neprilysin, some of those are going to be inactivated and no longer have that effect. And I'm not very familiar off the top of my head with the clinical trials. I know that Entresto was compared to enalapril, and certainly it's FDA approved, so it probably has some beneficial data that supports it. But that's another pathway that's currently being explored and now pharmacologically available for the management, I think mostly for heart failure. But the question, how much of a role could that pathway be involved in the management of hypertension, I think still is still out there and potentially explored. Yeah, again, I'm not at all up to date with that data, but that pathway is a pharmacologic target that's being used in people, and potentially something that we might see spill over into our patients as well.
Yeah, I think it's really interesting as well. We our group had another project in which we were looking at the RAS in cats, and we were interested in measuring neprilysin activity and submitted those samples to Adequant, the laboratory in Austria that was the original laboratory running the RAS fingerprint, and they try to measure neprilysin activity the way they always do, which involves, I'm pretty sure, I think Jane, our PhD student, is on the call. So Jane, please correct me if I misspeak. I'm pretty sure the process involves treating the samples with Entresto, and it didn't work at all. All of the neprilysin activities for our cats came back as 0. So one of the conclusions, we were sort of chit-chatting with the lab, and one of the conclusions we had is that maybe that drug doesn't work for cats, because we try to follow that up with some Western blots for neprilysin in the cat serum, and we can see that they have neprilysin as we would predict. It just seems like the assay didn't work, and they were wondering if it's because that drug didn't work for them, which is really fascinating. Cats like being cats.
They always make it difficult. They can never make it easy just to apply a different assay to. Well, it's awesome to hear that that is that's an area of research and just starting to crack that open to see how much of a role that might play. I guess I'm wondering, based upon this, is anyone questioning? We have really the ACVM consensus statements relying on not, and as this article points out, like the recommendation to not use amlodipine as the sole therapy in dogs because of the increase. I think that was from old papers just showing increase in maybe PRA and aldo, and so maybe in need of some update with the full fingerprinting to support that justification. But does anyone think, based upon what we're seeing here, that we should regroup and think about things differently in cats? Should we not consider amlodipine a monotherapy drug? Should it be something that needs to be given with other drugs, such as either an ACE inhibitor or an ARB or another drug? What does everyone think on that? I'll share my thoughts. So I guess I and Elizabeth, if you want to speak up, go ahead, because I've been talking way too much.
Well, hello from Australia.
Well.
I was just going to throw out. It was funny because when you brought this question up, because I've been thinking the same thing as we've been talking. What I've kind of done, again, I'm clinical. I'm not at a university, but I have used the amlodipine and not always been happy with the results, and played with the, once a day, twice a day, and which I think, from looking at some of the pharmacology studies, might make sense of why I've been doing that. But one thing I've always been frustrated by is really not seeing the amount of proteinuria in the cats, and maybe that's a diagnostic issue more than anything else that I see in the dogs. But what I've done in cats is I still do the amlodipine, and then I follow up and look at urine. If I've got a UPC elevation, then I will add in telmisartan a lot of times, just because it's easiest. It is a combination now. That's just me clinically, and they seem to do really well, and I don't have to use as much amlodipine. So that's kind of what I've been doing, kind of making it up as I go. So just as a comment, I've been playing with it already, but for several years. But I don't know if it's valid or not, or if anyone else is doing it, or if I'm off on my own.
No, I'm definitely right there with you, and have had a number of patients that receive dual therapy. Bianca, I think I cut you off as well.
No, you didn't. I think I was I think I was cutting you off unintentionally. Yeah, I was actually interested. I was going to ask folks about telmisartan, because I find the consensus statement such a wonderful resource and helpful read, but also slightly, the timing was off, just maybe by a year, right? Because truly a year after it was published, then the two large clinical trials looking at telmisartan in hypertensive cats were published, and so it was just the timing was a bit off. So I was curious to ask the same question about the use of telmisartan. In terms of using amlodipine as a monotherapy, my other concern, besides the RAS activation, sometimes, is the effects on intraglomerular pressure. And Dr. Scott Brown, I don't think he published this, but he showed me some of these data that he looked at that in cats as well, and showed that amlodipine, because of the preferential dilation of the afferent arteriole, since that's where the L-type calcium channels are preferentially located, increased intraglomerular pressure. And so I guess that would be the other thing to consider for some of our patients, especially if the blood pressure is not appropriately controlled.
Yeah, that is really an excellent point, that when you look at amlodipine causing afferent arterial dilation, you'll probably have no big change in renal blood flow in terms of the vasorecta capillaries, but you'll have an increase in the capillary hydrostatic pressure, which potentially could worsen glomerulosclerosis and shear injury. Now, curiously, we've have publications showing that amlodipine therapy and controlling blood pressure with amlodipine is associated with improvement in proteinuria. And if we're relying on proteinuria as just being our sole marker of glomerular filtration pressure, then that would suggest that that doesn't occur. Now, we could have spend another hour completely talking about the variability in proteinuria, especially in cats, and whether that's whether the spot readings are sufficient, and whether we needed to have more deeper evaluation of the magnitude of proteinuria in those patients to be absolutely confident. But using something that's going to dilate the efferent arteriole like an ARB would decrease glomerular hydrostatic pressure, which is the reason we worry about worsening GFR and the creatinine going up. But it does improve blood flow. So that you would actually have improved blood flow going to the vasorectal capillaries, and you potentially could see improvement in oxygenation. And we know that a microscopic hypoxemia, especially in the outer rim of the medulla, is really an important player and could contribute to the tubular interstitial fibrosis that could occur. So there's a lot of speculation that we can take that to that could potentially be pathologic. But at the same time, I think we generally see that cats, in terms of our practical biomarkers of blood pressure, proteinuria, quality of life, tend to tolerate amlodipine pretty darn well. And yeah, so it's interesting to know, are we looking at the right markers? Probably the most important thing is outcome, survival, progression of kidney disease, quality of life indices, more so than any of the tests that we can do, because that's really what's going to matter to our patients and to our clients. So it's but you can really take it down a bunch of different rabbit holes on 2 steps in the right direction, 2 steps in the wrong direction. But it seems like overall it's pretty well tolerated for most of our patients.
Yeah, you're so right, Jaden. And they really tolerate it well, and it's very cheap, of course. So I think the struggle with cats is often that we can never, or not we can never, but it's so hard to prove survival benefits and decrease progression with so many things, which probably is the point, right? As long as they tolerate well and are clinically doing well, that's probably good enough, maybe.
Well, we have what, 30? We've had 37 people on the call. If we all enroll 20 cats, we'll have a great multi-center study where we can really start to get some information here. And that's really what you need to do to look at it. When you look at the Benrick study at looking at benazepril in cats, a great multi-center study, well-designed, lots of cats that were enrolled, and there was not an improvement that was seen, but most of the cats were non-proteinuric. And I would argue that the dose of benazepril used in that study was pretty darn low. It was 1/4 mg per kg once a day. And certainly that's generally not my dose that I'm using in it. And so there's still so many unanswered questions that we have out there to pursue. So let's all sign up. We'll enroll some cats. We'll figure out actually some more significant survival data overall. Jessica asked, whatever happened to the big telmisartan study? And I said, I'm not sure. I'm not sure either. So I don't know if anyone has any participated in that and has any comments that they could share. All right. Autumn, did you have anything else, or I didn't know if that was the end of your slides, or if we were stealing?
No, that was pretty much the end, just trying to do discussion. And I wasn't sure. Hey, Bianca, is anyone planning on looking at RAS fingerprinting after telmisartan in cats? Are you guys planning on looking at that?
We've done it in dogs with proteinuria, and writing that manuscript. And I don't know if anyone has done it in cats. The challenge I see with the RAS fingerprint and telmisartan is that it's so weird to look at the bubbles, because angiotensin 2 goes way, way up. But then you need to keep in mind that the receptor, it's blocked, right? So if you just look at the graphs, they look very scary. And then you just need to keep in mind that the AT1 is blocked. But at least that's what we found in the proteinuric dogs. It was just a dramatic increase in angiotensin 2, and then subsequent to that, they also had an increase in the beneficial peptides. We presume because they had more substrate to generate those beneficial peptides as well.
No, Judy, I didn't really have anything else. I also was just going to comment that, like, in disease states like that, different things are affected that would affect potentially the afferent or efferent arterioles. And so I think that even makes it even harder to know, like, intraglomerular pressure when there's lots of other things that could be impacting those besides just like a healthy cat with amlodipine.
Right. And I guess the other thing to consider too is in the UK, certainly, and here in the United States, we have telmisartan as the FDA-approved drug to treat hypertension in cats. Has that changed people's practices? Because I think certainly we've had amlodipine for a lot longer before telmisartan was really kind of cracked into our world of being used. And even then, we probably use it in dogs a lot more than in cats. But does the fact that we have Simintra, does that change things for anybody? Are people using that preferentially because of the FDA product? I think that's probably more of a, I guess I'll just leave it there. Is that change people's practice? It hasn't changed mine. I whether that's correct or not, I still tend to use amlodipine as my first line drug for hypertension. Now, I will say, following up on the previous comments regarding the use of telmisartan as well too. If I'm the first person to check a blood pressure on a cat that might also have chronic kidney disease, and I find that it's also proteinuric, then I tend to turn to use telmisartan over amlodipine for hopefully getting additional reduction in proteinuria, where, as we've been saying, dilation of the afferent arteriole with amlodipine potentially runs the risk of causing an increase in glomerular hydrostatic pressure. So I do use telmisartan in those cats that are proteinuric and hypertensive as my first line drug. And if they're hypertensive and they're non-proteinuric with chronic kidney disease, then I'll generally turn to amlodipine for those cats. I don't know if that is a common practice amongst people, or are folks doing things different than that?
That matches my experience as well. I think one of the challenges with Simintra is that it's really expensive. And sometimes I have a hard time, convincing certain owners to spend $100 or so a month when they could use amlodipine for $2.50 with a coupon. So that is a big limitation for some of the owners that I treat their pets for CKD and hypertension and proteinuria and all of that.
Yeah, I would agree. It's definitely a big price difference. Sometimes we use the Simintra for dogs too, if they need a liquid and they're a small dog, but that's also still a big price. But I would prefer to do that personally than have it go to a compounding pharmacy that is going to make up a batch of liquid telmisartan every single time they need a refill, just for fears of the quality and consistency of an individual compounded product. I'd rather have it be from Simintra. But if you're bigger than a Yorkie, it's going to be extremely expensive. Certainly not something I've ever done with a Labrador, but usually labs, you can sneak a pill into them pretty easily. It's just some of the real small dogs that cannot be pilled per the owners, where we might turn to Simintra as well. Right.
And for whatever's worth, in our clinical trial, when we compared enalapril with telmisartan, what we used was Simintra, the same product that is currently licensed, which worked really well for the proteinuric dogs in our study.
Great. All right, well, we're coming close to the end of the hour. Any other final questions, comments, thoughts? I have one that I would love to get everyone's opinion. So maybe we can put it in the chat, just because that way I can try to tally things up a little bit, because I unfortunately can't set up a poll. But how do you pronounce it? Do you pronounce it renin, or do you pronounce it renin? What are you doing? Let's vote here. If you say renin, I guess you can spell it R-E-E-N-I-N. If it's renin, then yeah, it could be W-R-I-N-I-N or R-E-H-N-I-N. Looks like we have some renins that are coming up. 3 renins. Oh wait, there's one. Bianca's renin with me. I'm team renin. Larry Adams with renin. Oh man. Sherry and Sarah. Wow. Okay. This is overwhelming. Okay. It looks like Bianca, you and I are the only ones that say renin. Thank you, Larry, for your willingness to change. It's interesting because it is actually, if you go to some human conferences and discussions, they'll call each other out when people say renin versus renin, and it is you can even find papers that have editorials that talk about the pronunciation of the word, but it seems like the kidney nerds have really adopted it at being pronounced as renin versus renin, and there's some history to that as well too. But I thought it might be more heterogeneous, but it looks like it's overwhelmingly in favor of renin. Which
I think it's really fun. For whatever it's worth, I try to teach my students to say renin, and they all say renin because everybody else says.
Right.
But I try to tell them that it's because of the history of how we found it out, right? And it was the renal extracts from rabbits that were injected intravenously, and then they found that it raised blood pressure. So it's renin because of renal extracts, but they don't bite. They still say renin. So there you go.
Well, hopefully they all pass your renal physiology that you teach them as well too.
Absolutely.
All right. Well, that was awesome. Autumn, thank you for that. That was a great review of the literature and a deep dive into that paper, and really stimulated a lot of, I think, really interesting and stimulating conversations. So thanks everybody for coming and for joining in. We'll throw this recording up on the YouTube channel in case you missed it. And I'll send an announcement out with the paper for our next journal club, which I think... Is it in 2 weeks, Summer? Am I right there?
It's the third Tuesday. So,
third Tuesday.
Yes, in 2 weeks. Basically.
2 weeks. All right. Third Tuesday in 2 weeks. That's our next journal club. I'll make sure to send the announcement. Always check the website, the ACVNU's website, because it has the schedule as well as the articles. But thanks everyone for attending. This was fantastic. Hope you have a great week, and we'll talk to you soon.